Chairpersons, ladies and gentlemen, I'm presenting on behalf of the COMPASS Steering Committee and investigators, and here are my disclosures. Cardiovascular disease affects 4% of the world's population. That is about 300 million persons. Aspirin is the single most widely used therapy for long-term secondary prevention, but produces a relative risk reduction of only 19%. The results of trials with warfarin have demonstrated the potential for anticoagulation to provide additional benefit when used for long-term secondary prevention. But warfarin is highly problematic because of the bleeding risk, including a large increase in intracranial hemorrhage. Rivaroxaban is a safer anticoagulant than warfarin, and when used in patients with a recent acute coronary syndrome, reduces mortality. Building on this latter finding and using the same doses of rivaroxaban that were tested in the Atlas ACS TIMI 51 trial, in COMPASS, we set out to determine in patients with stable cardiovascular disease whether rivaroxaban, 2.5 milligrams twice daily in combination with aspirin 100 milligrams once daily, or rivaroxaban 5 milligrams twice daily, reduces cardiovascular death, stroke, or myocardial infarction compared with aspirin alone. In a second objective, we are exploring whether pantoprazole can prevent upper GI complications, and that part is ongoing. COMPASS included patients with stable coronary or peripheral artery disease and was designed to continue until 2,200 participants experienced a primary outcome. During a 30-day run-in phase, participants were exposed to low-dose aspirin, and those that tolerated, were adherent, and agreed to continue were then randomized into one of 3 treatment arms: the combination of rivaroxaban and aspirin, rivaroxaban alone, and aspirin alone. The expected follow-up was 3 to 4 years. The primary outcome, CV death, stroke, or myocardial infarction. There were 3 secondary outcomes. The first, coronary heart disease death, ischemic stroke, myocardial infarction, or acute limb ischemia. The second, cardiovascular death, ischemic stroke, myocardial infarction, or acute limb ischemia. And the third, mortality. The main safety outcome was major bleeding, defined using a modification of the ISTH criteria. The key difference between this definition and the usual definition is that we counted all bleeds leading to presentation to an acute care facility as major bleeds, irrespective of whether hospitalization was required. We also pre-specified a net clinical benefit outcome, which was the composite of the primary outcome and the most severe types of bleeding. The trial was conducted in 602 sites, and the 33 participating countries are shown in blue on the map. There were 9 countries where more than 1,000 participants were randomized. On February 6, 2017, the Data Safety Monitoring Board recommended discontinuation of the rivaroxaban and aspirin arms of the study. The reason for this recommendation was that for the comparison between the combination and aspirin alone, the threshold for stopping was exceeded. The threshold for the comparison between rivaroxaban and aspirin was not exceeded, although this result at that time was statistically significant. The closeout took place between March and June 2017. Mean follow-up was 23 months and follow-up was 99.8% complete. Participants were aged mean 68 years, blood pressure 136/78, cholesterol was 4.2 millimoles per litre, or about 160 milligrams per decilitre. 90% of persons had a history of coronary artery disease, 27% a history of peripheral artery disease, 38% had diabetes, 90% were taking lipid-lowering therapy, and 70% an ACE inhibitor or ARB. Here are the results. In the group randomized to combination therapy, there were 379, or 4.1%, who experienced the primary outcome. For rivaroxaban alone, there were 448, or 4.9%, and for aspirin, there were 496, or 5.4%. The hazard ratio for the comparison between the combination and aspirin was 0.76, a 24% relative risk reduction, which was highly statistically significant. The hazard ratio for the comparison between rivaroxaban and aspirin was 0.90, a 10% relative risk reduction, which at this time was no longer statistically significant. The Kaplan-Meier curve in the red for aspirin and in the black for the combination separated very early and continued to diverge throughout the period of follow-up. Rivaroxaban in blue produced an intermediate effect. For the next few slides, I'm going to focus additional information on the comparison between the combination and aspirin alone. The primary components of the outcome components of the primary were consistently reduced. Cardiovascular death, here are the numbers. The hazard ratio 0.78, a 22% risk reduction, P 0.02. For stroke, the hazard ratio 0.58, a 42% risk reduction, highly statistically significant. And for myocardial infarction, the hazard ratio 0.86, a 14% reduction, not nominally significant. Secondary outcomes were also consistently reduced. Again, for the combination versus aspirin alone, for the first secondary outcome, the hazard ratio is 0.72, a 28% relative risk reduction, highly significant. The second secondary composite, a 26% relative risk reduction, which is highly significant. And for mortality, 318 versus 378 deaths, a hazard ratio of 0.82, an 18% relative risk reduction, nominally significant, with a p-value of 0.01. Subgroup analyses in the two main groups in this trial, coronary and peripheral artery disease, were completely consistent. The benefits of rivaroxaban combination compared with aspirin were accompanied by an increase in bleeding. Major bleeding was increased by both groups receiving rivaroxaban-based therapy compared with aspirin. A hazard ratio of 1.7, which was highly significant. For the rivaroxaban alone arm versus aspirin, the hazard ratio was 1.51, also statistically highly significant. For serious or severe outcomes, event rates were low. Fatal bleeding, 0.1% in the aspirin group, non-fatal intracranial hemorrhage, 0.2%, and non-fatal other critical organ bleeding, 0.3%. None of these severe bleeding outcomes were significantly increased by rivaroxaban-based therapies. For the net clinical benefit outcome, the composite of the primary and severe bleeding events, there were 431 in the combination arm, 534 in the aspirin arm, a hazard ratio of 0.8, which was highly significant. Chairpersons, ladies and gentlemen, in conclusion, the COMPASS trial results demonstrate that the combination of rivaroxaban and aspirin compared with aspirin alone reduces the composite cardiovascular death, stroke or myocardial infarction, increases major bleeding but not significantly the most severe types of bleeds, and provides a net clinical benefit. There was no significant benefit of rivaroxaban alone. I'd like to acknowledge the many persons who contributed to this trial, and the results are being published simultaneously today in the New England Journal of Medicine. Thank you for your attention.